This year was an incredibly difficult one for me and my family. It all started one morning last winter when I woke up with right hip pain. Months of doctor visits, treatment, months on crutches and a cane ensued. And it was during those times that I leaned. I leaned on my faith, my family, some of my colleagues and friends. It was also during this time that I leaned on my primary care doctor. Being ill is one of life's most humbling moments. It is often during these moments when we yearn most for support. As a patient, it is often not just the medical diagnosis that we seek, but the connection, the human connection with someone who will listen, who cares, and who understands. The care delivery team, it is through this lens that we seek to know our patients, that we seek to provide patient-centered medical care to improve the lives of patient families. So as a pediatrician at Children's Hospital Primary Care Center, I provide care to a large underserved patient population. Over 2,000 of our patients have asthma, a chronic condition of the lungs that causes difficulty breathing. Many of our patients have high rates of emergency room visits and hospitalizations for asthma-related illnesses. Many are poor. Many have limited resources. Many also live in neighborhoods with substandard housing, with exposures to environmental triggers of their asthma. Triggers like old dusty carpeting, mold, secondhand smoke, and pests. Triggers that may worsen their asthma symptoms. Within the time constraints of the traditional office visit, I often felt limited, almost powerless in my ability to truly help my patient families. Office visits often ended with temporary solutions, medicine prescriptions, encouragement to take their medicines, and well wishes to my families. But it was really during my asthma patient sessions that I really became inspired and compelled to do more. During one patient visit, she said, "Mommy, don't cry. When you cry, it makes me want to cry." Her mom quickly dried her tears and said a few words of encouragement. My patient is Ladisi. She's a 4-year-old little girl with asthma. She lives with her mother and father in a 1-bedroom, low-income apartment. Both parents work. Her mom also attends school at night, pursuing a degree to better support her family. Ladisi has had a difficult time with her asthma. She coughs every night, all night. She's had over 3 emergency room visits in the past year because of her asthma. Mom reports good compliance with her asthma medicines, but she just does not seem to be getting better. Her symptoms are only better when she stays at a relative house. Both parents were smokers, but have since quit with the help of a cessation program in our clinic, after learning that secondhand smoke may also trigger asthma. Her mom reports problems with mice. They're roaches. The mice, they're everywhere. It's sometimes hard to make a meal because they're always over the stove. So to better help our patient families and families like Ladisi, we developed our Primary Care Center Primary Care Asthma Program. Our program consists of an interprofessional group of folks who work together to really improve the lives of patient families with asthma. Our team provides asthma education, we provide case management, and we also try to connect families to community resources to better meet their needs. So during one of their patient sessions, they meet with myself or my nurse practitioner, Linda, and we really spend time with families. What is asthma? What does it mean for your family? How do you take your medicines? Are you taking them correctly? And also, what are some of the triggers of your child's asthma? But it's also during these sessions that we really get to know our families. We learn their stories, stories often of struggle, but also of resilience and hope. So our asthma education sessions first started mostly as education. But then as we started to see more and more patients, we really began to realize that the magnitude, the volume of unmet social needs were great. It was often not the viral illness or even access to their primary care physician, but it was often the unmet social need that was at the core of their poor asthma outcomes. An office visit without the assessment of unmet needs was really a lost opportunity. So how can we ask this at every visit? How can we address this in very limited primary care office times, 15, 20-minute appointments? Really developing systems to not only ask, but to also address these needs and supporting providers to address them will be imperative. So as part of my primary care innovation fellowship and a quality improvement initiative in our clinic, we set out to better understand what are these needs, what kind of services we can provide to patient families. So we reviewed 100 case management files of patient stories to hear what families were saying. Over 96% of our patients had at least one unmet need. The average per family was 6. 83% needed help with environmental triggers of their child's asthma. 30% had financial insecurity, trouble with co-pays, the heat, the electricity being disconnected in the winter months because they couldn't afford to pay the bill. 29% needed help with stable housing. 22 of the families needed mental health support. Many of the adult caretakers, the mothers, the fathers, had no primary care doctor of their own to better care for themselves so they could better care for their families. So, as a result of this project, we have, for the first time, really started to identify and document the scope of needs that patient families face. We've started to develop an asthma education action sheet that providers and families can work together to identify just one targeted area of unmet need and an action step that can be taken at each visit prior to the next visit. We've also started to pilot a web-based needs assessment developed by Dr. Art Flieger as a way of potentially asking this at every patient visit. And we're also working with our social workers and our patient navigators to really develop systems of change to support providers and families as we do this. Sometimes we change because we're asked to. Sometimes changes in our circumstances demand a change. Because of my personal health experience, I too have changed. I value and appreciate more my health, being able to walk, run, and almost catch up to my young son. I deeply value the connections we've made with patient families. It is truly these connections, these personal stories, and investment in innovations that will change patient lives. And as we forge ahead in my clinic with developing systems of change, we really hope to integrate sustainable programs that will not only address the medical care of asthma, but will also address the social determinants of our patients' health. Thank you.